I'm Gary Friday. I'm a neurologist. Did train at Harlem Hospital for internal medicine and did my residency in neurology at Columbia, which also covered Harlem Hospital. So this was a while back, maybe about a little more than 30 years ago. I was going to talk about neurologic perspective. This is some information on visits to a neurologist. I practice now outside of Philadelphia, and generally it takes about, at best, 6 weeks to get an appointment with a neurologist. So there's not a lot of neurologists around in general. This was a survey done from 2006 to 2013. About 250,000 people responded. About 6% reported they had a neurologic disease, and about 2% actually saw a neurologist. Black participants were less likely to see an outpatient neurologist, and that's even after adjustment for other factors. And it's been shown that if you have a neurologic disease, if you see a neurologist, you'll do better. We already talked about some, Dr. Sims talked about Alzheimer's disease, also Parkinson's disease is a problem in the elderly. But I was going to focus on stroke. That's one of my interests. It's the leading cause of disability. It's the third most common cause of death. And the risk increases with increasing age. Fortunately, stroke rates have been decreasing for elderly blacks. For younger blacks, actually, we've hit a snag. It looks like it may be going up a little bit, but at least for elderly blacks, it looks like it's going down. But the rates are still higher for blacks compared to whites. So we still have that discrepancy. Types of strokes. Most strokes are ischemic, so blocked artery. We do have some acute treatments. Aspirin, TPA, tissue plasminogen activator. Actually, acute stroke rehab is not mentioned much, but that's actually been shown to decrease mortality by 5%. And thrombectomy more recently. However, when the artery gets blocked in the brain cells die pretty fast. So we still have a lot of disability even with these new acute treatments. So the money's really in prevention. And you have what we call primary prevention. That's for people who've never had a stroke, and then secondary prevention for those people that have had a stroke. So primary prevention usually is handled by the internist or the cardiologist, and the neurologist, we see them for secondary prevention. But it's really the same risk factors you got to control. So the most important is hypertension, and that was mentioned earlier. We're not doing very well with hypertension control. Most people aren't controlled. I was glad to hear that here at Harlem Hospital they're working on that, and they've made a lot of progress. Also, there's antiplatelet treatment, aspirin and Plavix. Anticoagulation, atrial fibrillation works very well. You can decrease your risk by about 70% if you have atrial fibrillation and you're anticoagulated. However, in general in the United States, we're not doing very well with that either. And in blacks, it's actually less. You can also do carotid endarterectomy if you have a stenosis in the artery in the neck. And now we can also do stenting. Smoking cessation is very important. And you also get some effect from lowering your LDL cholesterol. Fortunately, intracerebral hemorrhage, which carries a higher mortality, is becoming less common, but it's still about 10%. I guess back in the 60s, it used to be about 30% of strokes. There really is no good acute treatment. Sometimes we do surgery. We're not sure if that works. So really, again, it's prevention. And the main things there are hypertension control and smoking cessation. Subarachnoid hemorrhage is less common. It's about 5% of the strokes. That's an aneurysm that ruptures. Acute treatment is pretty effective, clipping or coiling of the aneurysm if you can get in time. And also prevention is effective if you pick up an aneurysm before it bled, with clipping again or coiling, hypertension control, smoking cessation. So people, if you've had a stroke, your risk of having another stroke is maybe about 5 to 10% a year. So that's where neurologists really focus, because we see the people that have had their first or second stroke. So they did a survey of stroke survivors. And those survivors and the elderly, more than 65 years old, blacks compared with whites had a greater frequency of no generalist visits. So they weren't, getting their risk factors controlled. Also, sorry. Also, there was greater frequency of inability to afford medications in blacks. And also in blacks and the elderly, they got to see the specialists less often. And that would be, usually after a stroke, you want to see the neurologist and the cardiologist. Those are the two specialists that are most important. The Institute of Medicine issued a report in 2003 looking at healthcare in general, confronting racial and ethnic disparities in healthcare, unequal treatment. And they had a committee on understanding and eliminating racial and ethnic disparities in healthcare. So I'm just going to go over some of their findings. So in general, racial and ethnic minorities have a lower level of health care, even basic medical procedures, than whites. And this is across the board, less likely to receive appropriate cardiac medications, less bypass surgery, less dialysis, less kidney transplants, less intensive care. And that's even after you take into account age, insurance coverage, income status, other conditions. And these differences lead to a higher mortality. And this is across diseases: cardiac, HIV, diabetes, kidney disease, stroke, and cancer. However, they do get more amputations. So less desirable treatments are performed more often in African Americans compared to whites. And they concluded that this is unacceptable and made some recommendations. So increased awareness of these problems by the general public, healthcare providers, major stakeholders. They recommended cross-cultural education and training of healthcare professionals, and we've been talking about that. They measured that we monitor the progress, which you've been doing here at Harlem Hospital, showing that you're improving things. And to provide research into the causes of these disparities and finding interventions to reduce this. So if you look at causes, so refusal of care, we talked a little bit about that, but that's apparently a minor factor. There are disparities associated with lack of health insurance. But as we see with people with Medicare, that's available to everyone, we still see disparities. So it's not sufficient to eliminate racial ethnic disparities. So that leaves us with biasing, stereotyping, and prejudice. And there's some studies showing that that's a factor. So these were some of the solutions they suggested. Avoid fragmentation of healthcare plans. So that's an argument for single-payer healthcare. Increase the proportion of underrepresented ethnic and minority healthcare professionals. We need to do that. I was at a talk by Dr. Sullivan recently. He was talking about blacks in medical school. And actually, black men, the numbers are dropping. So we need to work on that. They recommend increased resources of the Department of Health and Human Services to enforce the civil rights laws. And provide consistency of care through application of evidence-based guidelines. So if everybody's following the same guidelines, it doesn't matter if you're black or white, you're going to get the same treatment. And support use of community health workers. And I think that's it for me. There are some references I have that I used for my talk. And thank you.
So